Your conference is being recorded.
Okay, thank you everybody. So thank you for coming to this webinar today. This is the first in a series that we're calling the Intersections of Urban Indian Health and Environmental Health, Data, Programming, and Partnerships. So most of you may be familiar with NCUIH. We are a national membership nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare services for American Indians and Alaska Natives living in urban settings. And we're really excited to kick off the first in this series, and the whole series is supported by the Center for Disease Control's Division of Environmental Health Science and Practice, DEHSP, and the National Center for Environmental Health. So we really thank them for their support in putting this series on. We are also joined today by Mimi Narayan, the Principal Associate of the Health Impact Project at Pew Charitable Trust, and Alex Vollmer from the City of Minneapolis' Lead and Healthy Homes Project. I'm, again, Andrew Cowett, Research Associate here at NCUIH in the Technical Assistance and Research Center. I'm also joined by Mark Clark, the Program Manager here at CART. So I just wanted to quickly give an intro to Mimi, who is going to do the first section of this webinar. She's the Principal Associate at the Health Impact Project, which is a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trust that encourages state, local, and national level organizations to include health considerations in policy decisions across sectors, including housing, transportation, and education. At the project, she has been leading efforts such as the Climate and Health Initiative to support local jurisdictions in implementing replicable solutions at the intersection of public health and climate change to improve community preparedness and resiliency. And previously, she served as the founder and director of Catalyzed Research and Consulting, an organization providing strategic services to support healthy communities, with a specific focus on addressing health inequities resulting from the built environment. The impact of her work on communities has been featured in national and international publications and presentations. She holds a degree in architectural engineering, interior architecture, and received her doctorate in environmental design and planning, specializing in environmental behavior studies. We're also joined by Alex Vollmer, who's the Supervisor for the Healthy Homes and Lead Hazard Control Unit of the Minneapolis Health Department. Alex has an undergraduate degree in natural resources management and has been working in the fields of public and environmental health for the past 13 years. Alex has been in the City of Minneapolis' Healthy Homes Unit for 10 years, serving in a variety of roles, including housing inspection, grant development, and management, and has recently stepped into the role of supervisor for the unit. Alex maintains his love of the outdoors and wild spaces, but has found a professional passion in providing education and resources to the built environment. So without further ado, I'm going to pass things over to Mimi.
Hi everyone, welcome. I'm very excited to be here. I'm going to just set the context a little bit for sort of where we are, what we're going to be talking about today. So first we're going to talk a little bit about health and how we sort of are talking about health today, so we're all level setting and talking about it in the same way. And then I'll give a very brief introduction to the Health Impact Project, and then really turn it over to Alex to talk about their work at the City of Minneapolis to address these three main questions that we've been tasked with today in terms of sort of how the urban environment affects health, how urban Indian organizations can detect and respond to environmental issues, and how we can leverage some innovative partnerships to promote healthy environments, and how the city specifically works in that space. So to talk a little bit about how we are thinking about health, to really understand our role in making people healthy, I think it is really important to understand what drives health. And so our connection with our neighbors, the food we eat, because of where we shop, whether or how we get daily exercise, all depends on where we live, work, and play. So this brings us to sort of how the built environment is tied to our health. Many of the nation's most pressing public health problems, such as asthma or depression, diabetes, obesity, are influenced by those places that we're in. And so these social, economic, political factors, such as segregation or poverty, and whether people have social networks or not, whether they get to participate politically or not, the living conditions that we are in, our housing, our access to jobs, and good air and water quality, access to public services and infrastructure such as transportation, access to parks, etc., are all collectively termed the social determinants of health. And they drive our individual behaviors and health outcomes. So that is sort of the framing of health with which we are approaching the work we're going to be talking about today. And so our health is largely influenced by those socioeconomic and environmental factors, and it doesn't happen in a vacuum. So our built environment impacts our health both directly and indirectly, and that's why we are addressing those factors or root causes of poor health outcomes, such as those resulting from our housing, community safety, employment, education, and the natural environment as well. Policies and systems that drive decisions in those sectors impact our health. And that is really a lot of the work that my colleague here, Alex Vollmer from the city of Minneapolis, will talk about today, and specifically address environmental issues in the urban environment and how that impacts our health. So before I turn it over to Alex, I want to say a little bit about sort of the context that I come from and what the Health Impact Project does, which has been in partnership with the city of Minneapolis, and that's how we came to be at this presentation. So this is our team at the Health Impact Project. As Andrew so kindly introduced, my name is Majumdar Narayan, and I work with this team of wonderful folks at the Health Impact Project, a collaboration of the Robert Wood Johnson Foundation and the Charitable Trust, where really what we do is put health front and center, health as I've defined it just now, front and center of local, regional, state, and national decision making in sectors, that are outside of healthcare. So it's housing and all of those drivers of health, so transportation, education, criminal justice, etc. The project's goal really is that all people are healthy in mind, body, and spirit without having their length or their quality of life determined by social, economic, or physical factors. And so with that in mind, we're talking really about all people. And some of the ways in which we do this work is through tracking and sharing the work that we are doing, disseminating that, funding and conducting health impact assessments and other tools that we use in the field to provide TA, and we convene practitioners and other public health experts and folks in other sectors. The project was launched in 2009 with the goal of starting and spreading health impact assessments as one way of integrating health into decision making. And we fund a lot of health impact assessments across the country, but have taken that sort of place-based grant funding approach to the next level, if you will, where we are starting to scale health impact assessments and other tools to build on those lessons learned and findings from completed health impact assessments to what we call our toolkit. It's basically a database of resources that people can access, and I will be sharing that link with Andrew at the end of this presentation, so you all can have a link to that toolkit to support organizations on the ground to be able to integrate health into their decision-making processes. We are also engaged in sort of systemically doing this integration of health considerations into decision-making through what we call our SCALE project, and have policymakers or incubating approaches to change how policymakers consider health as they make decisions through something we call our health notes, which is similar to fiscal notes, but looking at how health will be impacted by legislation. We also have started to expand this work into emergent areas such as our climate and health initiative, which I will talk about very briefly in 1 second, and our Indigenous Health and Wellness Initiative, where we're working with Native-led partners to develop and implement community-led evaluation frameworks to measure health outcomes from an Indigenous perspective, which we acknowledge and know is very different than what happens in other places. So however we do this, whatever area of work we're engaged in, one of the things, or some of the things that we emphasize in our work is peer learning and sharing, cross-sector collaboration and strong partnerships on the ground, a lot of community engagement and bringing all kinds of stakeholders across sectors together, and then translating research into action. So to bring us to where we are today, our connection with the city of Minneapolis really stemmed through our climate and health initiative, which was a way for us to understand how the impacts of climate change are going to, what kind of impacts they're going to be on public health, and to really build resilient and healthy communities that can really stand strong in the face of those impacts. So we've funded 4 cities, including Minneapolis, to work on implementable, replicable strategies to make communities more resilient. And Minneapolis put forth a great proposal to create, to work with Little Earth of United Tribes, which is the only public housing community in the U.S. where Native Americans are given preference, to use the grant funds that we have provided to create a resilience hub that can operate essentially when the power grid is down. So to prepare the community for climate change impacts, but also make it self-sustaining and be able to operate during disaster. The city is working towards an 80% reduction in emissions by 2050, and part of this effort is to increase energy efficiency in at least 75% of all housing, both public and private, by 2025. And so this work, some of the work that Alex is going to share with you is going to be about some of that partnership with Little Earth. We're very excited about this work because the city of Minneapolis works in a very unique way to engage deeply and authentically with communities, which aligns with the way that we think about partnerships that can build on each other's strengths to improve health for all. So that said, I'm going to pass it along to Alex to talk more about the actual work they're doing on the ground.
Hi, everybody. Thank you, Mimi, for that wonderful introduction and background for health as well as the Health Impact Project. As Mimi said, my name is Alex Vollmer. I'm super happy to be here today, and thank you all for attending and participating. I'm really looking forward to being able to discuss our work that's going on with the Health Impact Project, as well as some of the kind of broader work that we're doing and have been doing for quite a while here in the city. So as Mimi said, my name is Alex Vollmer. I'm a supervisor for programs within the Minneapolis Health Department, and our goal is to promote healthy homes for our city's children and families. I'm very fortunate. I recently celebrated my 10-year anniversary with the city, and during that time I've had the privilege to serve thousands of Minneapolis residents, all through direct engagement, community partnerships, and policy development. I've also been a City of Minneapolis resident for nearly 15 years, so this work hits close to home, not only professionally but personally as well. I'm going to start by giving an overview of our work to date, focusing on two legacy health issues in Minneapolis, lead exposure and asthma. We'll briefly look at the history of housing development within the city, specifically the problems related to the densely organized and aging buildings that we live in. And then I'll talk about our various approaches to navigating these conditions, working with diverse communities, and we'll talk about the unique partnerships and programs that we've been able to develop in order to enhance the health and safety of Minneapolis residents. So like I said, I'm going to talk a little bit about environmental health. First, I want to discuss the public health. So the Minneapolis Health Department is responsible for oversight of public health inside of the city. And it's really population health as it relates specifically to people. Now, environmental health aims to affect the social determinants of health that Mimi discussed by working directly within the homes, businesses, and public spaces where our residents live, work, and play. In Minneapolis, we have long worked on building our programs to decrease the prevalence of lead exposure and asthma in our urban population. And these are like very highly specific health factors with clear outcomes. You know, there's a direct cause and effect. We can typically go inside of a house, we can talk with families, determine where the conditions are poor enough for these health impacts to have an effect, and we can kind of work with the family to mitigate those. Our emerging issue, climate change, it's a little bit more nebulous. But it's a topic that Minneapolis is taking a more holistic and systematic approach to in order to positively affect health by just continuing to learn with the community and working with them to mitigate the factors and impacts of a changing climate. So kind of talk about our city. Here's a map that kind of shows the age of residential buildings within Minneapolis. So Minneapolis is the most populated city in Minnesota. We have a little over 400,000 residents here. And our latest comprehensive plan is showing that we are going to continue to grow. We're seeing a migration back into urban centers for a lot of positive benefits. And so we anticipate that there's going to be an increased demand on housing inside of Minneapolis. Showing on this map, you can see that nearly 80% of our dwelling units were built before the year 1940, and most of that actually occurred between the years 1900 and 1920. A majority of Minneapolis is rental properties, and with the rental properties kind of comes additional vulnerability in a high demand city. We have a current vacancy rate somewhere between 2 and 4%. And that actually just increases exposure to market forces such as competition, and also sets up an environment for predatory rental and property transfer practices. From my standpoint, it's important that the city looks at housing as a public asset, which needs to be protected. So kind of building off of this, it's no surprise that housing this age comes with challenges and quirks. Add into that a city that's built with higher density, and that adds an additional layer of complexity. So we look through the lens of health in housing. I'm going to discuss 3 kind of potential hazards and conditions which can influence health and stability in an old housing stock like this. The first is just the increased upkeep and maintenance associated with these buildings. They're old, they've had a long time to kind of deteriorate and a long time to be deferred. I'm thinking about like paint and wall structure, roofs, and all of those systems. And what we need is specialized labor to kind of deal with some of those. We have lead-based paint, which requires special licenses and work practices in order to keep contractors, workers, and residents safe. And then thinking about like old plumbing and boiler systems might be wrapped in asbestos. Again, that takes specialized work practices in order to remove them safely and move them around safely. The second issue is just a higher demand on the structure over time. We've seen a number of houses with an increase in occupancy due to high rent costs. And because of that, the structures aren't necessarily built to handle that. You have increased water usage or that can cause mold. We have roof and other structural deficiencies, which can then lead to poor indoor air quality, which just very negatively affects the residents of the house. The third thing is the difficulty in making upgrades to better technology and materials. If you have lived in an old house or have talked with anybody who works on old houses, they'll pretty much unanimously say it's easier to just start from scratch rather than trying to retrofit a lot of things because of some of those quirks. But also some of those hazards. If we want to do weatherization inside of houses and insulate the walls, we need to be aware of electrical wiring that is in there that maybe not is capable of handling insulation. It wasn't built to handle loads of computers and microwaves and dishwashers and laundry machines. So those are some challenges that we are experiencing. But again, just wanted to re-say that in order to recognize that healthy housing is a cornerstone for a healthy community. People spend a majority of their time in their houses, and so we need to treat it as a public asset to ensure that it continues to be safe for our families. So I do want to start with our history of lead paint in Minneapolis as one of our large kind of health issues. So it was used extensively throughout the city. It had a lot of physical benefits, added bright colors. It's a mold and mildew inhibitor, so basically it kind of kills things. It can also withstand temperature extremes. If you've ever been to Minneapolis, you know that in any calendar year it'll be both 90 degrees Fahrenheit and negative 25 degrees Fahrenheit. So it's actually pretty remarkable that we still have a lot of paint that is 100 years old that is on our structures. In response to lead, for the past 30 years, we've kind of been primarily working in a response capacity. And what I mean by that is that once a child has been poisoned, we respond. As demonstrated on these maps, we've seen great success in decreasing the rates of lead poisoning by upwards of 95% over that time. And this is actually even with a decrease in the response level from 20 micrograms per deciliter down to 5 micrograms per deciliter. That's a good thing, and we now, because of that, are able to kind of focus a little bit more on primary prevention efforts rather than just a response effort. But despite lead paint being used throughout the city because of old housing, you can kind of see here that there's a distinct pattern of where many of our lead poisonings do occur. Unfortunately, these are also the areas of the city that have concentrated levels of poverty and are home to large immigrant populations and people of color. These are the areas where we want to be doing our work as we see the greatest need for it. Just a couple, I want to give two quick examples of properties to demonstrate the issue of lead and how that can become further a problem in urban environments. So here's one house. There's many health implications associated with exposure to lead, especially for children under the age of 6. Paint that has lead inside of it needs regular monitoring of those surfaces and specialized cleaning or training in order to maintain that paint properly. Otherwise, you might incur costly repairs in order to remove the paint. Based on those two needs, problems can occur through a deferred lack of maintenance or through improper remediation of structures. This is an example of a rental property that had extensive amounts of lead paint that had not been removed or maintained throughout the years. Unfortunately, this particular home had 3 children under the age of 6 from the same family with elevated blood lead levels, as they were using this 3-season porch as a play area and extension of their home. Here's a picture of the outside of the house. As you can see, there was deteriorated paint on both the inside and the outside of the structure, and most of it was in a deteriorated condition. The next property, this one had undergone renovations with unlicensed workers and was using unsafe work practices, and both during and after the renovation. We had no containment of the debris that was created and no cleanup for the property that resulted in a child being exposed and needing hospitalization. As you can see, there's a number of piles of debris that were left behind by the contractors, and the kid was drawn to that. And so here we have examples of two separate properties with a separate history but similar results. In order for our team to be effective when we're out evaluating these instances, it's critical for my team to be aware of the conditions that are close to home that can lead to increased risk for residents. That's our main concern, is identifying risk. We have found great success in meeting our families at their homes and providing a one-on-one consultation and guidance. And the next slide will kind of start to further demonstrate this approach. So as I said, deferred or poor maintenance at a primary residence is often to blame for a lot of lead exposure. But we do find that some of our families and our children that we work with live in houses that are lead safe or were built after 1978, which was when the federal government outlawed lead in residences, in residential areas. So the children we work with are typically between 1 and 2 years old, so their world is still relatively small. If the child is younger than a 1-year-old, they're often still closely attached to mom or other family members. And so in those situations, we have to kind of ask ourselves, where does the child and what does the child come into contact with? Foods, medicines, toys, other consumer products are typically provided by the family, and this might be another route of exposure. These types of situations may also extend to pregnant or nursing mothers if there is overlap in diets or product use with the child. Minneapolis has many residents. We're very lucky in this regard to have residents from Central America, Southeast Asia, East Africa, Middle East, in India, where product markets are not as regulated as they are here in the United States. There's a variety of reasons for adding lead to actually a lot of these products here. Color enhancement, same thing that they did with paint, particularly red colors, yellow colors. It's a heavy metal, so also if people are buying spices in bulk, you can add lead to that, and all of a sudden you've now increased your weight of what you're selling, even though if you're wanting to sell turmeric or chili powder, you're going to have an additive that's not going to be friendly to your clients. But that's how people make money. But because these products are used by families with various languages and backgrounds, there is an additional complexity to working with them in order to solve the issue. I'll get to the strategies that we use in order to combat that within a couple of slides. But first I want to kind of discuss our history and approach to asthma harm reduction. So here's a map, again, of Minneapolis, which shows the history of asthma occurrences between 2010 and 2014. This is the number of hospitalizations due to asthma exacerbation. The dark green areas have the highest rates. If you remember my slide from earlier, there is a stark overlap between this map and incidence of lead poisoning. Fortunately, we were given some new general fund dollars in 2019, which affords us a 50% full-time employee to kind of connect with schools, hospitals, and clinics in order to receive referrals. They are oftentimes our first line of defense in being able to meet with families, identify families, and get them support and resources. So with these funds and referral system that we've been able to set up this year, we're actually able to meet families at their homes where, like lead, sources can lead to exacerbation and a decreased quality of life. Also, it has long-term implications for school readiness, and so kids who are more prepared to go to school because of a good night's sleep are more likely to see success inside of school. So how do we evaluate those things? We start looking at our indoor air quality. We, again, start our investigation by looking at the spaces where child spends most of their time, in their house, in their beds, in their living rooms. We use EPA and CDC developed checklists. We perform qualitative and quantitative analysis of the home to determine opportunities for asthma exacerbation. Part of the funding that we do have allows for product purchases and deployment. And the reason why we were able to get this funding is because a previous study that we conducted in a partnership between ourselves, Housing and Urban Development, UCARE, which is the Minnesota State Health Insurance Program, and the Minnesota Department of Health, we have found that reported incidents of school absences were decreased by upwards of 12 days per year, and a decrease in days with asthma symptoms by upward of 21 days per year simply by performing these interventions. And we had a cost of less than $400 to the property between staff time and product placement. So that's an incredible, I mean, if you think about 12 missed days of school, all simply over, $400 worth of dehumidifiers or hypoallergenic mattress and pillow covers, that's an incredible return on investment. We also have a coordination between the health department and our regulatory services department, which allows us to write corrective orders on rental properties in order to gain compliance. Repairing water leaks in bathrooms and around the foundations of buildings are most common, and so using some of that quantitative review is incredibly important for us in being able to communicate what the needs of the house are. So kind of getting back to the communication strategies and how we are working with our families. The first thing I'd like to talk about is just finding common ground. Like I said, many of our families are from diverse backgrounds, different ethnicities, in different languages, so we need to be able to communicate with them. We use interpreters, we have staff on hand that reflect the community that we work with. But sometimes we need to, it's not just that simple, and we need to take a bi-directional learning approach where we are learning from the families as well as providing knowledge to the families. So for instance, we might be looking at a particular product we have suspicions that are causing like lead exposure. Depending on where the family is from, that product might have different names. Kohl is an eyeliner. It might also be called Surma or Saut. And in order for us to know that and be able to make sure the family is aware of that, we start to build our knowledge bank. We'll use photos of particular products in order to make a stronger connection with the families. Also, we use this with lead. We kind of talk about some of the visual indicators of lead-based paint. For us, there's a term called alligatoring, but not everybody is aware of this. But then we show a picture of lead, or we have a building component that has lead-based paint on it, and the families can immediately say, oh yeah, that's exactly what my house looks like. So we use a few different strategies there. We got to try to find that common ground. Additionally, we like to talk with our families about what is being used and how the family is using products or their house. This could be related to access to paint for children. We often use siblings as kind of a tell for where children are spending their time. Is it in a closet? Is it under the bed? Sometimes. Is there a question?
There should be.
I'm going to continue. So sometimes moving furniture can solve the problem immediately just by moving the child away from a particular building component. So we kind of need to rule out other sources, again, because we're looking at risk. We want to find the riskiest areas for the families to make sure that we can use our limited resources to be very impactful. The third thing that we kind of strategy that we use is by demonstrating empathy. Again, with some of these products, a lot of them hold cultural and significance to families. Whether it's a medicine where it's just kind of, they say mom or grandma used to give me this. If it's using some sort of ceramic cookware that has lead glaze on it, it's the same thing. This is my grandma's pot that I used to cook my beans in, and it can be really difficult to give that up. One of the things that we try to talk about is offering alternatives for those particular products. We do some testing to provide lead-free bean pots or crock pots to kind of achieve the same results. Make recommendations about using family heirlooms, maybe as planters or decorations, so they can stay with the family. But knowing that they have the choice to kind of determine how that use is going to be. Another thing that we like to talk about is access to new opportunities and new behaviors. For instance, helping kids deal with lead resiliency through healthy diets and fresh vegetables. So we provide them with vegetables. If you don't know what kale is, we can give you some kale along with some recipe cards to ensure that you're familiar with it and know how to use it and can start to integrate that into your diet and your child's diet. Another thing I don't have on here, but it's also looking at the social determinants of health. is because we know that it's not just, there's a lot of additional factors that can cause particularly lead exposure or asthma exacerbation. In rental properties, we frequently hear the rebuttal from property owners of, well, tell the kids to quit chewing on windowsills and walls, and we know it's not that simple. And one of my biggest pet peeves is this blaming the victim mentality, and defensiveness from landlords is definitely not very welcome. But now I want to kind of talk about building on our partnerships. I briefly touched on effective partnering with our clients to help learn about what they're experiencing and how we can serve them. And now I'd like to briefly discuss the programs involving our grant partners. So the three that I would like to talk about are climate change resiliency, community-supported agriculture, and block-by-block lead testing. We believe that growth within the community and partnerships with the community allow us to innovate and better serve the needs of our clients and our families. So we need to get advice and guidance from our communities about how to proceed and how to engage with them. First thing I'm going to talk about is our community-supported agriculture program, because I think this is really unique and it involved a lot of parties and has kind of gone into a lot of different avenues. So this is a recent partnership from a couple of years ago that we were working to develop a community-based science, a support, and a resource. We had input and guidance, like I said, from multiple agencies on what the garden should be. We were using a product called biochar, which is it's kind of like charcoal, but it's a manufactured product made out of organic materials. And what it does is that it helps fix nitrogen in the soil, retain water during drought conditions, and we've created this product that's mixed along with a compost that was procured by and developed by Native American community, the Minneapolis Sioux. They run a compost production facility, and so using this biochar in partnership with their compost allows for just insane results that allow us to bring potential benefits during drought years or hot years, and some of those items that are trying to address that changing climate. Some of the other goals of this particular project are reducing the bioavailability of heavy metal contaminants, so we're looking at ways that we can make lead as inaccessible as possible, knowing that there is lead from gasoline and from paint all across the city. How do we make it so that the risk is lower? One of the nice things as well that we got some feedback on was utilizing these soil components that honor those cultural practices. The biochar actually kind of mimics the idea of slash and burn, where you take all of your organic material and by releasing that carbon, it allows for regenerative agricultural practices in the soil, helps build up that soil health to make sure that you have good mineral composition for your soil. We found good success with this, with the three sisters, with beans and squash, and it was in corn, and we found, again, super success with it. The third thing that it does, the last thing that it does, is it promotes healthy eating with vegetable varieties from native lineages. Not only did we look at specific plots for how we can, for the different soil compositions and their success, but we also used it by taking these native lineages of corn and beans that are being maintained by the Minneapolis Sioux, and kind of looking at it as a way to further produce those particular varieties. In addition to this, we know that healthy diets equal healthy kids. So we know that whole foods are high in iron, calcium, and vitamin C. And that is a good defense for the body against lead absorption. And so what we wanted to do is we actually provide veggies from this community-supported agricultural plot to our families at our elevated blood lead investigations. Again, this kind of just reinforces the message, breaks down some of those barriers. When people are living inside the city, they might be living inside of a food desert where they don't have really great access to healthy foods. So here's another opportunity. Again, introducing new vegetables, introducing new foods is also about learning how to use them. So it reinforces that message of lead resiliency while also supporting our urban farmers. In addition to all of that work, we use it as an opportunity to promote other community events as demonstrated by that board that was in the previous slide. But I wanted to give a close-up map of the garden, which details the land and contact information for this particular project. As you can see here, there are a number of initiatives and outcomes contained within the garden and community outreach opportunities. We've hosted community dinners there where people learn how to use the vegetables. They go out and actually tend to the garden, pick the vegetables, and then go and cook with them right afterwards. So we've hired chefs from the community to engage with that. We welcome community members to come and participate on the garden and help pull weeds or plant vegetables or tie up trellises. All those different things. So we think it's a really great opportunity and really unique to build out partnerships and build out opportunities for the community, not only to engage, but grow and learn and be innovative. Another thing that we are looking at is this block-by-block lead testing. Not only are we wanting to respond to lead poisoning, but we want to increase testing rates so we know that we are keeping our families healthy. This is a partnership that we have with a nonprofit organization called Sustainable Resources Center. They have the Leady Eddy van, which is a mobile testing and education unit that we are able to bring these services directly into the community. And what we're trying to do here is increase testing rates by decreasing barriers to receiving the service. Getting a test means you have to go and visit the clinic. They oftentimes do a screening test, which does not confirm the presence of lead inside of your system. So then in order to do that, you have to go back to the doctor and get another blood draw. For anybody that has little kids, we know that can be really difficult. So we want to make sure that there is an opportunity to get these services directly into the community. We have lead-specific education. Again, we use photos of lead-based paint to make those connections. We have building components that we've pulled off that have lead paint on them. And we also have lead-contaminated products that we can demonstrate. Here you see these bean pots as well as a crock pot to kind of demonstrate a before and after about how to use these products. Also, by doing this block by block and being able to go out into the community, we can tailor our education materials directly to the neighborhood needs with specific ethnicities and languages that are unique to each neighborhood. How do we ensure that we're visiting the right neighborhoods? Here is another map of the city which shows our historical how we evaluate blood lead levels in the city. Again, you see these patterns emerge based on the type of housing and location. The most colored areas are high in rental property ownership, as well as high immigrant populations and populations with people of color. The red, blue, green shows where the most kids have been poisoned and exposed. And knowing that we have over 200,000 dwelling units within the city, we're not able to hit all of those from a prevention standpoint. But if we know where the greatest risk is, then we can allocate our resources appropriately and have a greater impact on specific sections and neighborhoods within the city. So each one of these little squares is a block, and on those blocks are between 15 and 20 homes. And so again, we have the ability to kind of look at this critically and make sure that we're getting the correct resources into the city. And here's another map kind of demonstrating how that's actually played out for us. We do this evaluation of all of these areas and where we need to provide our resources. We get data and support from a variety of departments, just even within the city of Minneapolis, including our Community Planning and Economic Development agency, which provides data analysis for program development, again showing where people are living, what those communities are composed of, where those finances associated with those communities, so we can get our resources out there. Our Regulatory Services Department offers partnership for rental properties where a majority of lead poisoning and asthma cases are occurring. We work with the Minnesota Health Department to get blood lead reports and guidance documents for our outreach and education. We get funding from the federal government in order to do lead renovations in houses, and that's exactly what this map is showing, the number of renovations that have been completed and houses that have been made lead safe in response to lead poisonings within those communities that I was demonstrating through our other maps. And then we work with our neighborhood groups like community agencies such as Sustainable Resources and neighborhood hubs that are directly located within the communities. That gives us access to residents, gathering spaces, and community events where we can provide support for our programs and connect community members to our resources. The last partnership that I want to talk about is actually our climate change resiliency, where we're kind of, again, taking that holistic approach and looking at the impacts of climate and health. This is what we're doing with our funding from the Health Impact Project. As Mimi mentioned, we are working with the Little Earth of United Tribes in the city of Minneapolis. It is a 212 dwelling unit facility, and she said that it gives priority to American Indian residences. And so our program goals are listed on here, but just to kind of talk about those a little bit, we wanted to develop a working partnership and reciprocal process for emergency preparedness, including planning, response, and recovery. So we feel that connecting with the community on a regular basis puts a face to a name at a place that people trust will help facilitate better response and recovery in emergency situations by developing those protocols before the emergency situations. We are collaborating with the elders inside of the Little Earth Resident Association to provide education on health-related impacts of climate change. We've developed education opportunities and to discuss what can be done during emergency situations. We've also put together some emergency response kits for all of the residents who are living at the facility, so that way they can be ready and can respond to certain incidences. The third thing is that we're doing is offering energy audits with a community partner, Center for Energy and Environment, to determine energy score of the residences. During these, we kind of look for holes in the walls or inefficiencies that could be contributing to poor health or just comfort and livability of these units. So in addition to the energy audit, participants also receive energy-saving products such as LED light bulbs, door weather stripping, programmable thermostats, and low-flow shower heads. So these are immediate products that can be used to reduce the energy consumption of the house, as well as the overall cost of living burden of living in these urban areas. We are also able to offer families suffering from asthma, this is either adults or children, a review of those home-based asthma triggers. We check for pests, talk about upholstered furnitures and carpets, indoor air quality from smoking or air fresheners or pets, and areas with high moisture content. Again, a qualitative and quantitative analysis allows us to kind of tailor our interventions for our families, and then the qualifying families do get those products placements to help reduce some of those triggers. The last thing is that we have some funding from our energy providers to install solar installations as part of our overall city goals to reduce energy consumption within the city. So we are actually installing a solar installation as well as battery storage at the facility, which will help, again, reduce overall cost burden of living, as well as be able to maintain consistency and better respond during climate-related extreme temperature situations. So ultimately, what we're doing is we're moving into a more holistic way of evaluating the health needs of residences as it relates to their home environment. Just as a quick example kind of everything that I've been talking about, if we replace 100-year-old deteriorated windows with new windows, we can address a number of issues all at the same time. One including lead-based paint, water intrusion and condensation. This is because of single pane windows with no storm windows. Again, we have these huge temperature extremes, so you have a warm interior to cold exterior on a single pane window that's like ripe for creating condensation, which can lead to deterioration of wood products. It's an organic material, so we get mold buildup on that, which can lead to asthma exacerbation. And then also just the energy inefficient single pane windows. Again, higher cost burden, non-insulated walls and poorly insulated windows increases the amount of money it costs in order to just live inside of a house, let alone the rent associated with it, but just the energy usage. So that's what we're trying to look at. We realize that there is a lot of opportunities to overlap. We're trying to break down the silos across our enterprise, understand the full implications of our work, and provide an increased value to our clients and our customers and our families at a time when margins and resources are becoming increasingly thin. So that's it for me. So with that, I think my time is up, and I want to thank you all for your attention and participation today. And I'll turn it back over to Mimi and Andrew and Mark to wrap everything up.
Yeah, I think Andrew, you can take it away from here.
Thank you. Thank you both for sharing that information with us. It was really great information. I did want everyone to know we're actually in the middle of a storm here in DC, so our phone and power lines went down in the middle of your information, Alex, so we're not able to see if anyone writes into the chat box. But we are still here on the line. I just wanted to see if anyone had any questions for any of the presenters here today. First off, any questions about different partnership models, ways for urban Indian organizations to get involved? And you can either type into the chat box and we'll look for your questions there, or you should be able to click the phone button at the top and speak your questions in through your microphone. Just open it up to the room. All right. So with that, if you have any questions, we're going to send out our contact information to everyone who's attended the webinar today, as well as the slides and a link to an evaluation later if you think of anything. I also wanted to make a note, if you are at an urban Indian organization and you attended the webinar today, keep an eye out for a survey that will be going out, and we will be asking the different urban Indian organizations about their priorities around environmental health and programming, and also to assess the work being done so we can communicate the interest and needs to different partners we have around environmental health. We'll also be having a second webinar coming up in November around national, local, and clinical data related to environmental health and how that can be used for programming, grant writing, and epidemiology. It looks like we are having some questions come in as well. So I'm going to have one of the other associates here at NCUIH read that out.
Yes, can you hear me?
Yes, thank you.
The question is, in regard to asthma, is there a model of integration for working with schools? And I believe that question would be for Alex.
Yeah, I'll take a stab at that. So the Minneapolis Health Department is actually really fortunate. One of our units inside of the health department is it's school-based clinics. So we have a whole team of nurses and medical assistants that are placed in our public school system throughout Minneapolis. So we have access to those populations. Otherwise, I would recommend connecting with your school board and developing a memorandum of understanding for how you could relate information back and forth. I think that they're very interested in making those connections if you have program resources to provide to them. I know it can be a challenge to get past the legal hurdles with sharing youth medical information. So I can't necessarily speak to the specifics within your state or district, but that would be probably the first route that I would go.
Alex, there are no other questions in the chat box at this time.
All right, thank you. So again, we'll send out contact information if anyone has any questions that arise as this information kind of sinks in. But otherwise, thank you so much for attending today, and I'll follow up with all of you via email for webinar part 2. And again, thank you all for coming. Thank you so much to our presenters today. And with that, I will conclude the webinar. Thank you.
Thank you.
Thank you.
One. Yep. That's down.